All right, so it looks like we've got a good number of people called in, so we'll go ahead and get started. A few housekeeping things before we hand it over to Naomi, but just wanted to let people know that your lines are automatically muted when you called in as an attendee, but if you could keep your line muted just so we can reduce background noise. We do have quite a few people called in today, so we want to make sure everyone can hear as well as possible. But if you do have questions or comments or anything, please use the chat or question box through GoToWebinar, and I will be monitoring those throughout the call and will pass any questions or comments along to the presenters. We will also be using a couple of polls during the presentation, so please pay attention to your screen during that period, and you'll be able to enter your answers to the polling questions as well. So with that being said, I will go ahead and hand it over to Naomi to get us started.
Great. Thank you, Alexis. Good morning, everyone. My name's Naomi Newman, and I'll be a presenter for this session. And we've got a packed agenda for today. We'll start with introductions, then we'll review the objectives of the session and what you can expect to get out of it. Then we'll dive into what value-based payment is, or VBP, as the jargon goes, and why Washington State is focused on it. We'll also discuss Healthier Here's role in supporting the transition to value-based payment, and we'll review the capabilities needed to succeed under value-based payment models. And lastly, we'll open it up for a discussion about what the transition to VBP means for you and your organization, and we're hoping this last part will be a conversation. In terms of process, we'll pause throughout to take questions, and we've left ample time at the end as well for questions. And as Alexis mentioned, if you can mute yourself when the presenters are speaking, we'd appreciate that, and then we'll create opportunities for Q&A throughout. Before diving in, you'll notice that some of the slides are very jargon heavy or dense, and I'll explain these as I go so that you can learn the jargon as well and learn to navigate your way through what I like to call the alphabet soup that is healthcare. So now let's go ahead with introductions. This session is sponsored by Healthier Here, and Twee is the CFO. Twee, would you like to introduce yourself and say a little about Healthier Here?
Thank you, Naomi. Good morning, everyone. Thank you for joining us this morning. We hope that you will find this very useful at the end of the session. Again, my name is Twee, and I'm the Chief Financial Officer for Healthier Here. Healthier Here was created from what we call the Medicaid transformation waiver from the state, which establishes 9 communities of health. And Healthier Here locates obviously in the King County region. Our focus really is all about building and strengthening partnerships, especially across sectors, as well as developing networks between the community and clinical partners. We also do a lot of investment strategies where we send out investment dollars to support our partners in different ways, which could be technical training for different purposes. For example, this is one of them. We also try to build capacity infrastructure with these investment dollars with our partners, as well as drive innovations for best practices in healthcare to improve. At the end of the day, what we want to do is create a system of care that will work best for everyone and focuses on quality outcomes. So thanks again for joining us this morning. And again, if Naomi and I use some of those alphabet soups, please feel free to ask us questions, and we'll try not to. Thank you very much.
Great. Thank you, Twee. I'm Naomi Newman. I'm a director at Manat Health, and Manat Health is an integrated legal and consulting practice, and we help clients all across the healthcare industry solve complex problems with the goal of improving access to care and improving quality of care. And I have experience working with provider organizations primarily to prepare for the transition to value-based payments and to build up their population health capabilities. I've been working with Healthier Here for 2 years now, advising on a variety of strategic initiatives, and have worked elsewhere in Washington State as well. So, and we have a couple of organizations that have graciously offered to share their experiences with us throughout this presentation. So I want to thank Karen Brady and Krystal Heineck from Ryther and Ethan Soraka from Sound. And I'd like to invite them to introduce themselves and their organizations as well. Karen, are you on the line?
No, that's Krystal. She's not, I don't think she's on the line. She's at another training. She'll be here pretty soon.
Okay. Krystal, would you like to introduce yourself and the organization?
Sure. I'm Krystal Heineck. I'm the Senior Director of Outpatient Services at Ryther. So we are a pediatric-based organization, mostly children, typically 2 to 24, accepting Medicaid and private insurance for behavioral health, mental health, and substance use disorders. We do, like I said on the screen, all the things. Also case management, a lot of evidence-based practices, and work with a lot of folks in the community. We have therapists in different community organizations and partner with folks so that we can really try and reach clients where they're hard to reach and where there's barriers set up. So that's Ryther.
Great. Thank you, Krystal. Ethan?
Hi, Ethan Soraka, Director of Whole Health Innovation with Sound. Sound is a traditionally behavioral health treatment organization serving at 17 outpatient locations in King County, and currently looking to expand as well. We have, over the last few years, begun a transformation from doing mental behavioral health substance use disorder treatment to actually integrating primary care services into our treatment and making sure that we are fully integrating with all of our providers. And then we serve individuals across the lifespan, as young as, I think, 2 or 3, all the way through end of life.
Terrific. Thank you. Really excited to have you on the call with us and look forward to the insights you have from your transformation journeys in Washington State. So now I'd like to get to know our audience a little bit better. So we've got 2 polling questions here, and we're going to take them one at a time. So first question is, what is your role? And there are 5 options here. One is physical health provider, behavioral health provider, executive or administrative staff, case manager, or other. Alexis, I'll hand it over to you to explain how the poll works.
Yeah, so you should see on your screen the polling question that Naomi just read off. So if you can just click on the option that best fits your role, we'll give people about a minute or so to fill this in, and then we'll switch to the next polling question. All right, and it looks like a majority of people on the call have put in their responses, and a vast majority, or 64% of people on the call are listed themselves as executive and administrative staff, 21% as behavioral health providers, and 13% as others. So we'll be able to share the final results of that poll after the end of the webinar, but we can go ahead and switch to the second question now, Naomi, if you're ready.
Great, thank you. So what do you know about value-based payment? 3 options here. I'm completely new to the topic. I'm familiar with the basic concepts only, or I'm knowledgeable about value-based payment and have experience with it as well.
All right, and it looks like a majority of people have entered their responses for this question as well, and the most common responses is 65% of our attendees say that they are familiar with the basic concepts only, followed by 26% of attendees who said they are completely new to the topic.
Okay.
So I'll go ahead and close this poll, and it should switch back to your slides.
Great. Great, thank you, Alexis. And that's helpful for me to get a feel for how quickly I should go, whether I should speed up or slow down. So it sounds like we have folks who are familiar with the topic, but by no means experts and really interested in understanding what VBP is and the implications for their role. So we've designed this to be an introductory session, and through today's session, you can expect to develop a basic understanding of what VBP is and Washington State's goal. So basically the answer to what is VBP and why is it important. We're also going to discuss how the transition to VBP is impacting care delivery models and community-based organizations. The goal is to understand the capabilities your organization may need to be successful under VBP and consider the potential implications for your work. So this addresses the question of what does VBP mean for me? And then lastly, we'll spend a little bit of time also understanding the role Healthier Here is playing in supporting providers and community-based organizations in King County in transitioning to value-based payment. So now we're going to dive in, and I want to start by sharing a few facts and figures to set the context for this conversation. These are about healthcare costs in America, and understanding these numbers and trends helps understand why there's a strong push to change the way we pay for healthcare in this country. So as you likely know, U.S. healthcare costs are high and growing steeply. And as you'll see on the graph in the upper left, the U.S. spends over $10,000 per person per year. That's an average across everybody. So we spend significantly more for some and significantly less for others on healthcare. And that is almost double what other so-called developed countries spend. And you may wonder, what are we spending all this money on? And as you'll see from the graph in the lower right, it's primarily hospital care. And it would be one thing if we had the best care in the world, but we really don't. And in fact, quality is highly variable, and many people end up getting tests and treatments that they don't need. In fact, there was a study a few years ago of Medicare patients that showed that a quarter to 42% received at least one useless test or treatment. And another study that showed that if all hospitals performed like the best hospitals in the country, then 164,000 complications could have been avoided, and importantly, 220,000 deaths could have been avoided. So the bottom line, the reason I'm giving you this context is we spend a lot of money on healthcare. It's really expensive, and the care we get is highly variable in terms of quality, and some of it is of no value to the patient. So because of this situation, there's a movement, and this movement is led primarily by CMS, the Center for Medicare and Medicaid Services. That's the government agency that oversees Medicare, which is the health insurance program for seniors and people with disabilities. And CMS also oversees Medicaid, which is the program for people with low incomes. And Medicaid is a partnership between CMS and state governments. So CMS has really been driving transition to higher value care. And what do we mean when we say value? Well, at a basic level, the value of healthcare is the quality of care you get divided by the cost of care. So to maximize the value, you need to increase quality and decrease costs. And the theory behind value-based payment is that if we change how we pay for care, and if we pay for value of care instead of volume of care, we can improve quality and reduce costs. And here on this slide, you'll see in blue the traditional, what we call fee-for-service model, contrasted against value-based payment models. So under the current fee-for-service model, the more care you do, the more you get paid. Under the value-based model, you may be rewarded for doing less care if it's the right care for the patient. So you're really incentivized, and this is through what I'll call carrots and sticks, to focus on managing costs while still delivering high-value care. And under the current model, there is very little incentive for providers to work as a team or share data with other providers who care for your patients. It's very siloed. And under the current model, the fee-for-service model, the focus is primarily on physical health. There's little recognition or reward for coordinating with other people who care for that patient. And there's also little recognition for thinking about other factors that may be impacting a person's health. But under a value-based payment model, since providers are rewarded for keeping costs down, and if you recall from the prior slide where the majority of costs lie, they lie in hospital care, providers are really incentivized to engage in proactive care management to keep people healthy and out of the hospital, because that's how you can keep costs down. And when you start digging into which patients are hospitalized and why, you realize that it's not just about their medical condition, but often about their mental health. It's also about non-medical things in their life, like do they have stable housing? Do they have access to nutritious and regular food so they can manage their blood sugar levels if they have diabetes? We call these other factors, these non-medical factors, social determinants of health. And community-based organizations, like the ones on the line today, play an important role in meeting those needs and helping patients address that side of their needs, so that when they get care, they're able to heal and really benefit from the value of healthcare. Otherwise, it ends up being a vicious cycle where they go to the emergency department and aren't able to get out of their health predicament. So as providers get paid differently to care for patients, they need to begin to think about how best to care for the whole person. And to do that, they need partners. And that's very different from the current model. So just a quick recap here. The theory is that if we can create rewards for providing high quality and low cost care, or penalties for not providing it, we can change those cost curves, and patients can benefit from lower costs and better outcomes. Providers benefit because their patients are more satisfied. They're working in a more efficient environment, focused on doing what's right for the patient. They're collaborating with other people who serve those patients. And then payers, these are for instance, the Medicaid managed care organizations in Washington State. They benefit because now providers are partnering with them to try to control costs. So let me pause there, because we've just defined at a very high level what value-based payment is, and I want to check if there are questions.
And just to remind everyone, if you can enter your questions either into the question or the chat box in your webinar screen, I can go ahead and share those with Naomi.
Okay, I don't see any questions coming through, so we're going to keep going here. So why is there this movement? Well, we talked about why, the motivation for this transition to value-based payment. But it's really the Affordable Care Act of 2010 that accelerated the momentum to shift from our fee-for-service payment model to a value-based one. And Medicare, as I mentioned, that's the national insurance program for seniors and people with disabilities. They launched a variety of initiatives to promote the creation of accountable care organizations. And in these organizations, a group of providers agree to be assigned a group of patients and to be responsible for meeting quality and cost standards for those patients. And if they're able to save money versus expectations, then they get to keep some of that money. It's called a shared savings arrangement. And that we're seeing the proliferation of ACOs in the Medicare program, but we're also seeing state governments promote value-based payment. And in Washington, 5 years ago, the legislature directed the Healthcare Authority to tie 90% of its healthcare payments to value by 2021. So this is the money the state spends for Apple Health, its Medicaid program, and it also impacts the money the state spends for its own employee health programs. So this is a very, very ambitious goal. When you look around the country, this is a very ambitious goal to make sure that the state is paying healthcare providers for the quality of care and aligning them to manage the cost of care. And Washington is going about this through what's called the Medicaid Transformation Waiver. This is an agreement between the state and CMS. We won't go into details, but suffice it to say that through this Medicaid transformation program, the Healthcare Authority created accountable communities of health. Healthier here is one of 9 in Washington state. And these accountable communities of health are responsible for promoting and supporting that transition to value-based payment so that providers are rewarded for quality of care and for cost management. But the thing is, it's not like you can just flip a switch and say, okay, today we're paying you for the volume of services and tomorrow we're going to pay you for value, and there, we've solved the problem. If providers are going to be paid for value, they need to invest in things like data systems so they can track quality, and they need to track cost and then be able to report on it. And if they're going to focus on keeping patients out of acute settings, they need to build up care management programs to prevent readmissions. They need to build up primary care so that they can address issues before they become complex. And they need to think about coordinating with other providers across the system. So all of this requires work and investment. And that's what this partnership between CMS and Washington is all about. It's a 5-year agreement to help Washington state transition from the existing fee-for-service model, which you've got here on the left, to the transformed value-based payment model. Through the Medicaid Transformation Program, you may see and hear the term DSRIP. DSRIP stands for Delivery System Reform Incentive Payment Program. This is a program between state Medicaid agencies and CMS, and it's authorized through 1115 waivers. I'm sharing this just so you have the lingo and you know what it means if you hear it. But what's important to know is Washington's DSRIP program, it's referred to as the Medicaid Transformation Program, and it's a 5-year agreement between the state and CMS to invest in providers and the community to be able to transition from fee-for-service to value-based payment. The idea is that as you make these foundational investments, the appropriate infrastructure and partnerships and population health management capabilities will be put in place, and providers will then be able to track and report on quality. They'll be able to monitor and manage costs, and they'll be able to deliver care in a very different way that should ultimately improve outcomes and try to bend those cost curves that we took a look at earlier.
Hey, Naomi, we did have one question come in, if this is a good time.
Sure.
So we had a question come in, so they ask, if incentives, which drive the overall cost of any payment model, whether it's fee-for-service or value-based payment, remain, how is the overall cost of the program actually reduced?
So if incentives remain, so let me see if I understand the question. I think under the fee-for-service model, the incentive is you do more, you get paid more. Under the value-based payment model, the incentives are changed so that you are rewarded for meeting quality metrics. For instance, if you manage a population of patients with diabetes and you're able to keep their A1C levels under control and within a certain band, you may receive a bonus payment for that. So that's a very different incentive than just if you're paid just to see a diabetes patient, regardless of the outcome of their situation. So the idea is the incentives are changed through the payment model changes. I'm not sure if that addresses the question.
I think the question is, so the result of that switch, which you're talking about, which is the incentive, is that because the focus is on quality, potentially the long-term costs of complications or unnecessary emergency department use or those types of things would be the overall factor that would drive down the overall cost. Is that correct?
Yes.
Okay.
Yeah, exactly. So, going back to that diabetes example, under the fee-for-service model, you see your diabetes patients and you see more of them, you get paid more, but you're not necessarily rewarded for keeping their A1C levels in a certain band. And some of those patients may end up in the emergency room, or they may end up getting complications that require more care, more medication. So that drives up the cost. But under the value-based payment model, after this transition, you're rewarded for proactively managing their health and trying to avoid the complications that may ensue from diabetes, and those complications are the things that drive up the costs.
Okay,
so I think
great.
you're exactly right on the incentives there.
And then we actually had a follow-up question come in from another listener, which is, does this switch in incentive provide an incentive for providers to avoid chronic or difficult to cure patients?
Yeah, and that's a good question. Could this value-based payment model lead to what we call in healthcare cherry picking? And there are guardrails against that in terms of how patients are attributed to health plans and who's accountable for the care. So, because today the incentive is not only focused on reducing costs, but also monitoring quality, there's an incentive to avoid that cherry picking. But it is a risk, it is a risk. I think that has to be negotiated between the payer, the managed care organization, and the providers. And the idea is that through this DSRIP, through these Medicaid transformation dollars, providers will be equipped with the technology and the care teams to be able to manage those complex patients. And there's also an acknowledgement through a process called risk adjustment, where those complex patients are recognized, and the complexity of caring for them is acknowledged in the rate that the provider gets for caring for them. So the provider will be paid more for caring for a complex patient than they'll get for caring for a patient who is relatively easier. And that attempts to address that concern around cherry picking.
Naomi, this is Twee. I would just like to add that we also want to see people patients receiving the services at the right places, and also focusing on preventative care, so that to avoid, I think it was Alexa's comment on use of emergency room, so that folks can receive care in their primary care setting to avoid the emergency room visit. That's where we're also focused as well.
Right. Yeah.
Okay.
So there is, I think it's a important concern. Our provider is going to try to avoid caring for complex patients, but there is a process called risk adjustment, which recognizes the complexity of caring for those patients and gives providers more resources and higher rates to care for those patients. Because it's important to the health plans that those patients receive care. Because if they don't receive care, they'll end up in the emergency room and they'll end up costing more. So we're going to move on.
Yep, I was just going to say that was the last question for now, so we're good to go. Thank you.
Great. 1 second here. And as I mentioned, you know, there's this agreement between the Centers for Medicare and Medicaid Services and Washington State. It's a 5-year agreement to invest in what's called delivery system reforms. So these are the changes to how providers practice and deliver care. These are things like investing in the IT systems, building up the care management infrastructure, building up the connections between providers and community organizations so that they can be successful under value-based payment arrangements. Because without this funding, you have a bit of a chicken and egg problem. Doctors need to change how they practice to be successful under VBP, but they need money to change how they practice. So the idea is that these funds from CMS and the state enable providers to change how they practice, and then that change allows them to generate savings, improve value, and then reinvest those savings into their care delivery networks. So let me pause there. Are there any questions about the transition from fee-for-service to value-based payment going on in Washington State?
So we did receive one more question, and Naomi, it's not specific to Washington State, so it's up to you whether you want to answer it now or perhaps later in the presentation. But the attendee asked, many patients see more than one provider at the same time. How can you attribute improvement in the general health to a specific provider?
Yeah, and that's a great question, and it's actually one of the complexities of value-based payment. But under these models, patients are attributed, that's the term used, they're attributed to a practice. And then that practice or that doctor is responsible for coordinating all of their care needs. And we'll go into the various models in a little bit, but essentially there is an attribution methodology, and that creates the incentive for that primary provider to coordinate with other providers on the care for that patient. So that's in some of these more advanced value-based payment models. And that, so, you know, that provider is incentivized to partner with other providers. Okay, great. So now we're going to talk about the role of accountable communities of health in this transition to value-based payment. I like to call this slide my alphabet soup slide, since there are 3 acronyms in the title alone. The HCA has certified ACHs to support this transition to VBP. So what does this mean? Well, it means the Healthcare Authority of Washington, which is responsible for Apple Health and Medicaid, certified 9 regional nonprofit organizations to help providers make this transition from siloed, volume-driven care to value-based care. And I'm going to ask Twee to explain the role of the organization of Healthier Here and how they're helping with this transition.
Thank you, Naomi. So before I start, I want to also remind or put it out there that the waiver or the Medicaid transformation project actually began in 2017 from the state and the federal standpoint for the waiver. So we started this journey in King County around 2017, and the waiver is going to go through 2021. Healthier Here has chosen 4 areas of transformation or focus areas. Out of the 8, the state provided 8 different projects, and Healthier Here chose 4 of those. because we want to really concentrate our effort and focus our efforts on and do well in these areas. And you've heard them before, most likely, is the bidirectional or just integration of physical and behavioral health. We also want to focus on transitional care, which is where a patient is released from the hospital and how to transition them back to their home and community. Addressing the opioid crisis, and then chronic disease, which is consisted of cardio, diabetes, and asthma. So back in 2017, and even before 2017, there have been conversations around what do we want to achieve with this waiver. It's a great opportunity for the region. What would be success, or how would we define success at the end of the waiver? As the governing board actually helped us answer this question back in late 2017, and they actually gave us 4 answers. First is that we want to really create authentic ways to incorporate community and consumer voice into our healthcare decision making. And so Healthier Here, for instance, these are examples that we've started. We have the Community and Consumer Voice Committee as part of the advisory committee to our governing board structure. We also just established the Tribal Advisory Committee to help us elevate tribal voices. The second vision for success is that we want our care teams in King County to really be representative of our cultural diversity, be competent and respectful of our communities and individuals, because at the end of the day, we want to honor the differences, the diversity we have in King County. Third is the computer system, or this is more of data systems, where we have a lot of data, pieces of information sits everywhere. We want to be able to link those data to inform decisions that from a business standpoint or clinical standpoint to help with the care, providing care, and create that community and clinical connections. And I think you might have heard us, we've been starting to work on what we call the Community Information Exchange, or CIE. This is where we want to be able to have data linkages between the CBOs and the clinical folks. This is an example of where we're heading to. So more to come on that. Lastly is the payment models that we've been focusing on as relate to value-based payment. We want to avoid the what we call the fee-for-service or pay on based on volume, but focuses more on the quality and outcomes. And here we actually think that there's an opportunity between building the value of the community-based organizations, because they are a part of the healthcare system and they will contribute to the better outcomes of our patients and clients. So at the end of the day, these are the 4 focus area or visions of success that Healthier Here has been defined, and that's what we're reaching for. With that, I'm going to turn it back to Naomi.
Great, thank you. And as Tui mentioned, Healthier Here selected 4 areas of focus for supporting the transition to value-based payments. One is bidirectional integration of physical and behavioral health. 2 is addressing the opioid use public health crisis. These are 2 required initiatives by the state. All other regions in the state are also working on these. And then King County also selected transitional care and chronic disease prevention and control. And now we'd like to get a sense of whether these issues, these 4 issues that Healthier Here is focused on, impact your population. So we've got another polling question here. Which challenges face the populations that you serve? And please select all that apply. So Alexis, I'll turn it over to you to open up the survey.
Okay, great. So you should see the survey question up on your screen now. And as Naomi mentioned, this one is a little different than the first 2 because you can actually click more than one option. So we'll give people just about a minute to fill this out, and then I'll be able to share their responses. All right, we've still got some answers rolling in, so I'm just going to give people a couple more seconds, and then I'll be able to close the poll and share the results.
Great, thank you.
All right, so now you should see on your screen the results of the poll with the percentages of who selected which, and we can see that unmet substance use and or behavioral health needs was the top ranked one, but really a fairly even distribution across the different project areas.
Okay, great. I can't see the results, but you said unmet substance use and behavioral health needs is top.
Yes, 85% of people that logged in said that that was a need within their community, and followed by transitions from institutional settings back to the community, which 71% of people said impacted the community that they worked with.
Right, yeah. And yeah, that's interesting because those, so for the first one, you know, unmet substance use and behavioral health needs, those are two of the priority areas of focus for Washington State. They're really eager to address the opioid use disorder crisis and separately, or connectedly, I should say, integrate physical and behavioral health needs. So Twee gave an overview of what Healthier Here's vision of success is. And one of that is supporting that transition to value-based payment. And Healthier Here, it's a nonprofit organization. It's doing this through a variety of activities. And I'm going to ask Twee to comment on some of these activities that they've organized to support partners in this transition. And then I'd like to also ask the two partner organizations on the phone, so Krystal and Ethan, to comment on how their organizations are making the transition to value and the benefits they've received from the partnership with Healthier Here. So Twee, I'll start with you first. Do you want to speak to some of the activities you've been supporting?
Certainly, I'll be happy to. So I'm going to go from the left to the right. We as Healthier Here, we see ourselves one of the most valuable ways that we can contribute to this conversation is be a neutral convener, in that we do not have any biases. So we set the table and we would engage with folks to start the conversation. So in this arena, we partners regularly and communicate regularly with all the across the sectors within King County. So that would include the managed care organizations. We have 5 of them in King County. We also have providers, healthcare providers that are hospitals, federally qualified health centers, and then the behavioral health agencies, and then also the community-based organizations. We connect with providers and with one another, and it's by holding what we call co-designed or collaborative settings that we talk about, where we talk about equity. We talk about one of example is the Value-Based Payment Academy, et cetera. We also facilitate our ongoing communication between stakeholder groups. So we see ourselves as setting the table and then convene a conversation and then try to problem solve through those conversations and initiate some actions. The second area we focus on is providing educator. Purpose for that is mostly for TA, so technical assistance. We use our dollars and contract with certain experts or subject matter expertise out there, and then provide the training for that and offer that with all of our partners. The other is we also see ourselves as a regional strategy developer, where we can actually see and assess the current situation with the input of our across the sectors with all the players. And then we identify through that, because we have this balcony view, which is really unique in that we can see the different areas of needs assessment and feedback, and then identify the regional needs, and then prioritize how Healthier Here could play a role in that. We also develop strategies and address needs by leveraging existing resources, and that could be having conversations with our managed care partners, and then linking them up with our providers in healthcare as well as the CBOs as we move forward, and prioritize what those areas are and then pursue them. We obviously leverages the dollars that we receive through the what Naomi described earlier, the DSRIP, which is our waiver, through our waiver. This is a one-time incentive that we could work through to make these huge changes or work within our county. So this is, again, where our investment strategies, if you've been involved in here, the conversation in the 2019 investment strategies, we focus on 3 areas: the providing infrastructure and build capacity with our providers, and then have a co-design where we explored what needs are out there and better understand them, and then see how we could address them. And then lastly is our innovation fund, which is where we focus on certain areas of one area that we've issued or working with is called the medication assisted therapy, with providers to explore ways to innovate and incubate great ideas, and then see how that works, and then scale and sustain it. The other is the 4th role that we see ourselves doing is as a driver of sustainable reforms. So we want to support approaches that providers have the capability to develop, so that we can reduce cost, the overall cost, healthcare system costs that Naomi described earlier, with the value-based payment efforts. And then we also want to advance initiatives that are in line with the state's managed care contracts requirements, and then work with cross sectors. So here we see ourselves a couple areas in the work that we do with the collective ambulatory optimization is how to work with this information across the sectors. And then we also provide one-on-one technical assistance, again, through contracting with experts, experts. And then the last area that we focus in is being an advocate to basically champion for practice transformation. This is where we provided the value-based payment academy. Again, it reflects also reflective of our work on the collective ambulatory optimization. This is where we really want to be the voice and advocate for support to our providers and what is needed in King County. With that, I'm going to turn it back to Naomi.
Great, thank you. And I'd like to invite Krystal and Ethan to talk a little bit about their transition to this value-based payment world. Hearing a bit of an echo. Oh, it's gone. Okay, so to talk about their transition to value-based payments and whether and how Healthier Here may have supported or is supporting their transition. So, Krystal, do you want to start?
Sure. I have Karen here as well with me, so she can join in as well. So we have started, I think that Healthier Here has been incredibly helpful in getting us on our way and helping us understand our position and what we need to position ourselves well for value-based purchasing. So I think for the most part, we've participated in all the things that you named there on the screen. The in-person academy events have been super helpful to kind of understand the change, what value-based purchasing is, what the expectations will be, and how we can start thinking of ourselves that way as an agency. And so having space to really sit down, understand, work through different worksheets and stuff, and that's been great. We were provided some of that money you were talking about for a new EHR. Our last one was not helpful in collecting data and really aggregating that data. So we have a new EHR that we're learning to use to help collect the appropriate data that we can use for looking at HEDIS measures and our project that we're working on. Our project right now really focusing on improving the integrated care at Ryther, and more specifically aiming at a reduction in hospitalizations for clients with asthma. Since we are a pediatric facility, asthma is probably the most driving cost factor for children. So we're trying to focus on that as a template and a goal, and then we can expand that and have other integrated models and pathways. So using the webinars and coaching calls as well to help expand that project have been, again, extremely helpful to break down steps, look at how we can engage staff, creating our log frame and pathways for our project, almost like a project management training to help us think in that way so we can get ourselves in a good place to show good outcomes. I've also gone to the co-design collaboratives, and I think those were helpful, and like I think you had said, creating conversations, sitting in a room with behavioral health and physical health folks and trying to speak a similar language when there's a history of approaching things a little bit differently and maybe a power differential there. So really interesting to have a conversation start of how do we integrate care and start to show better outcomes for clients and decrease hospitalizations. We have to speak to each other, and how do we do that? So that's been really great. So, I mean, I don't know, our Healthier Here has been incredibly helpful in us getting ourselves set up for that. I don't know if you wanted more from
I think the other thing that just from trying to get the board of trustees to understand what's happening, were a lot of the information sort of out of the gate that Healthier Here provided to the community, and the slide decks. I used a lot of those about trying to explain to the board about here's the world that's coming, and this is what we need to be thinking about in terms of positioning this agency, that there's a whole different way of looking at the world, and what we need to start thinking strategically as an agency about managing, and what it means about integrated care with physical health care providers, and what does that mean about interacting with community-based organizations, and not just co-locating services, but more integration, so that they understand why some of the decisions that are being made in the agency are being made. And so that's been also very, very helpful.
And Karen, can you speak to how you envision payment might change for your services over time as a result of these efforts?
So I think what's going to be really critical is for us, sort of what Krystal talked about collecting data about who do we have, how have we been able to, if there's early benchmarks about like emergency room utilization or hospitalization utilization, how have we as an agency helped change that trajectory for a child or a young adult to reduce emergency rooms. So in addition to getting sort of paid as a provider, maybe it'll be a capitated rate or a modified fee for service. But if we're able to sort of show through data and HEDIS measures and all the data that is being collected by the MCOs on claims, can we show here's the part that we played for each of those clients, or on an aggregate basis across the board? Here's what we were able to do, and here's the piece that we played in that, and then do we get part of the savings? Mm-hmm. So, and then how do you do that with a pediatrician? And like if you have a child with an eating disorder, how do you work with that physical health care provider to keep that child out of an inpatient setting and to manage that progression in a way that promotes health instead of more acute care?
Right. So getting rewarded for the part you're playing in improving quality and reducing costs.
Yes.
Great. Thank you. Thank you, Krystal and Karen. Ethan, do you want to chat a little bit about Sound's integration of physical and behavioral health and how that's going?
Certainly. So with Sound, what we realized a few years ago is we thought we had data. We thought, oh, we're collecting a lot of information. And what we came to realize is we did a really good job of collecting free text fields that created qualitative data that was really hard to analyze or very labor intensive. And so we actually started a few years ago trying to figure out how do we quantify qualitative work. And the reason for that is we needed to understand who our clients are, how we serve them, what their needs are, and be able to identify ways that we could meet them. And so we started really redesigning and redeveloping how we collected information so that we could speed that process along, as well as make what we collect usable in actually looking at what we have. And so, along those lines, we've redeveloped forms, we've redeveloped kind of clinical process, but we've also redeveloped the way we deliver care. And so we're doing a lot more now as far as measuring client outcomes, measuring changes in different dimensions of clients' lives, and had adopted a practice from Mental Health Center of Denver called Reaching Recovery that gave us a better opportunity to really tell the story of what we do and how we serve clients and how that impacts them. The purpose being is that we want to be able to go to our payers and be able to say, this is who we serve, this is how we serve these conditions, and these are the outcomes that they get, and be able to demonstrate that in a way that is data-driven. The reason for that is we want to be able to control how we serve people, as opposed to having the payers tell us how to serve somebody based on a score that may not be fully representative of their needs. And so we feel that kind of this shift will put us into a position where we not only understand our clients, but we understand our clients' needs, and then we can identify with our payers what their needs are and how we can work with the individuals we serve, or they impanel with us, to actually meet those needs in a way that's beneficial to all three entities. Because really, at the end of the day, the most important thing, or the biggest driver, is client outcomes, whether that's reducing costs or making sure that we're providing quality services with what we have. And so we really invested in that. And so we've done a lot of work around investing in our data system. And so we have built a data warehouse that can store and analyze data directly out of our EHR in a much more robust way than some of the built-in features, at least on the behavioral health side. And then we also took it a step further and invested in a data analytics visualization program so that we could create real-time dashboards as well as reports that give a fuller understanding of data, but also allow us to work with and analyze data in a way that's much more user-friendly than trying to process Excel spreadsheets or access reports. So that was a big thing. And I think Healthier Here has been really helpful with this, both through their investment in project participation, as well as some of the drivers that they've done around how to understand value-based payment, and the academy they've put together and hosted, and then some financial incentives as far as doing that. But they've also, I think, really kind of helped hone the area's vision of what we're moving toward in integrated care and kind of collaboration. And so now we are able to use the collective ambulatory, collective medical EDI package much more robustly to identify our clients, as well as to share care information and visit information across providers through the care guidance system. And then I think the next step we've kind of taken on through, again, the driver being the value-based academy that we started on a few years ago, which was really understanding how to do QI, QA, and using that PDSA, PDCA model to really not only identify areas of opportunity within the organization and how we serve people, but then also making sure that what we're doing makes sense, and then going back and refining that process so that it is becoming more cohesive, as well as constantly being improved and refined, so that we are staying current with changing trends, changing therapies, changing needs of the system.
Yeah, that's terrific. Two really great examples here. And, I hear common themes across both of you in terms of investment in IT systems, whether it's an EHR or a data warehouse layered onto the EHR that lets you extract information about your patients and better manage their care, And I'm also hearing that that leads to changing care models or a culture of continuous improvement where you're looking at the data, you're looking where there may be gaps in care and working to continuously close those gaps and having that feedback loop with the data to tell you how you're doing. And then using that information to say, hey, MCOs, here's the value we're delivering. We'd like to be rewarded and compensated for that because we're helping to keep patients with asthma out of the hospital, or we're helping to manage minor health issues to avoid them from becoming acute conditions that require higher levels and more expensive levels of care. So two really wonderful examples there. Thank you both for sharing. We're going to now take a closer look at value-based payments because there are different levels. There's a spectrum of financial risk that providers can take on, and there are different capabilities that you need to succeed the more financial risk you take on. So there's the Healthcare Payments Learning Action Network. This is also an organization affiliated with CMS. They developed this framework that is really helpful for understanding and classifying value-based payment models. So on the left, you've got category 1, and this is the fee-for-service world. So this isn't value-based payment. There's no link to quality or value. This is you do more, you get paid more. And then moving to the right, this is where providers receive some payment that is linked to quality or value. And as we discussed earlier, and as the two organizations shared, to be able to be paid for quality and cost, you need to be able to track quality and cost. So let's use diabetes as an example. To report on quality, you need the data systems that tell you how many patients you have who are diabetic and whether they're receiving the right care at the right time. So 2A is a model where you get paid for building up those systems. These are foundational payments for infrastructure and operations. This is very much around capacity building. And then 2B pays you for generating the data that says how many patients you have who have diabetes, what their A1C levels are, whether they're taking their meds. So this is paying you for doing the reporting. And then 2C takes it up a notch and pays you for your performance. So are you actually keeping those diabetic patients within the appropriate range for A1C? Are you appropriately managing them? Are you connecting them to the specialists they need? Are you making sure they come in for their tests? And are you helping to manage their their comorbidities? And then 2D takes it one step further where it layers on penalties, where if you're not meeting a threshold of quality in managing these patients, if you have too many patients falling through the gaps, then you have a financial penalty for that. So that's category 2, which they call fee-for-service with a link to quality and value. And then moving over to the purple, you've got category 3. This is APMs built on fee-for-service architecture. So APM stands for Alternative Payment Model, and this is a payment that is alternative to the current fee-for-service model, and that term APM is often used interchangeably with value-based payments. So again, going back to the alphabet soup, lots of acronyms, but it's just a way of saying it's a different payment than your regular fee-for-service. And here, under category 3, we've got a couple of examples. So let's say you have a population of patients, and the MCO, the payer, says, for this population of patients, I project that the costs will be X dollars, just based on historical trends. But if you can save money by actively managing their care, keeping them out of the hospital, avoiding unnecessary services, connecting them to the preventive care they need, and if through doing that you save money, then you can share in that savings. That's category 3A, APMs with upside gain sharing. Upside gain sharing is just a complicated way of saying shared savings. And then 3B layers on what they call here downside risk, or essentially a financial penalty. So let's say the payer says, I've got this population of patients, I project the cost to care for them will be X. If you manage to care for them at less than X, then you get to share in those savings. However, if you exceed X plus some percentage, then you're responsible for that increased cost. You now bear some of that financial risk for caring for that population. So what you'll see as we go from left to right here is the provider progressively taking on more and more financial risk for the patient. And then in category 4, this is what's referred to here as population-based payment. So this is where the provider will get a certain amount of money to manage an entire population, and it's up to that provider to figure out how to manage that budget, and they're responsible for that budget. And the best example in Washington State is the Kaiser system, Kaiser Permanente, where they receive a per member per month premium. So they get a flat rate for per member per month, and then they manage their patients within that budget. And if they exceed that budget, if they have patients who go to the hospital and incur lots and lots of costs, then that's their loss. But if they actively manage those patients and are able to save money, then that's considered savings that they can then reinvest. Since they're a nonprofit organization, those savings have to be reinvested into the care model. So as we move from left to right, more and more financial risk is being shared with providers. And this is intended to align the providers with the payer's incentive to manage costs. But it's not just about pushing down costs. There are quality metrics throughout for each of these that providers are held to make sure they're not cutting costs at the expense of quality. I think this was a concern of one of the participants early on when we were discussing incentives. So there are quality incentives layered on here. There are expectations. In Washington State, they have what they call the common measure set, which lays out a series of quality metrics and quality targets, and it rewards providers for meeting those targets. So that's how the state incentivizes quality. So we mentioned this earlier. The Healthcare Authority in Washington has an objective of 90% of its healthcare dollars in value-based payments by 2021. And what do they mean when they say value-based payments? They mean category 2C upwards. So there has to be some evidence of performance, meaning evidence of improvement in quality and or reductions in cost. So that's the Washington State's definition of value-based payment. They want 90% of all of the healthcare dollars to fit within one of these new types of payment models. That's a pretty substantial shift that's happening in the state. And the state is actually making good progress on that objective. In 2017, 50% of Medicaid or Apple Health payments were linked to value, with actually 42% in category 3. Category 3 is that shared savings or shared savings and shared risk model. And we have a couple of local examples of value-based payment that we wanted to share with you. So just to make this a little more concrete and tangible. So category 1, fee-for-service, this is not value-based payment. This is still, over half of the payment that happens between the payers, the managed care organizations, and the providers. Still the traditional fee-for-service model. But we are seeing, and we have examples for all of these other categories. So as an example of category number 2, in 2009, community clinics providing integrated physical and behavioral health care in King County piloted a program in which 25% of annual funding was contingent on meeting quality indicators. So that's a pay-for-performance type model. If you meet these indicators, you'll get a funding bonus here. Category 3, this is a good example of this are the Medicare Shared Savings Programs, or the Medicare ACOs, Accountable Care Organizations. And there are a variety of medical groups and clinics that are participating in these. The Polyclinic, Valley Medical Group, Health Connect Partners. And what they do is they agree with CMS to care for a defined population of Medicare patients. And if they're able to exceed, to keep costs below a cost threshold and meet quality targets, then they get to share in those savings. And I'm not sure which model they're in, but they may also have a penalty if they're not able to manage costs successfully or not hit those quality metrics. And then the last category is population-based payment, and we mentioned Kaiser earlier, so integrated delivery systems. But these population-based payment models can also happen on a smaller level. You could have surgeons taking on what's called a bundled payment model for example, a hip replacement. So in this model, the payer will say to the surgeon, surgeon's practice, we'll give you, say, $25,000 for a hip replacement. And this includes the 30 days pre-op and 30 days post-op, and you're responsible for managing all the expenses related to that episode of care. And, you know, if the costs exceed that $30,000, then that's your responsibility. So now the surgeon's practice, they're not just responsible for going into the OR, and operating on that patient. They're now responsible for making sure that patient doesn't have an infection, doesn't get readmitted in a few days, and has the appropriate physical therapy support and other supports to heal appropriately and return to their daily life. So it really changes the incentives and forces a change in how clinicians care for patients. So I'm going to pause there.
I'm going to say we have a couple questions that came in, if this is a good time.
Great. Let's go ahead and take those.
All right. So one question was related to examples of both this focus on outcomes as well as reducing costs. So I know we've given a couple of examples of some physical health, like the hip replacement and diabetes, but this participant was asking if you can provide some examples of what that would look like in the behavioral health field. They said sometimes it's hard to make the translation from things like diabetes that have some more easily measured outcomes and make that translation to behavioral health where things maybe aren't as clear cut.
Sure, and I think the opportunity is really at the intersection between the two, behavioral health and physical health. So I'll say a little bit, and then I'll invite the two guest presenters to comment as well, since they're both behavioral health agencies. But an example is, let's say you have someone who struggles with a mental health issue, and they also have physical health issues, and they end up in the ED. And without addressing their mental health issue, they're unable to tackle that physical health problem that keeps landing them in the ED. The ED is the most expensive place to get care, and it's really inefficient. So if you can create or connect that person to the mental health services that allow them to stabilize their mental health condition and engage in self-care and engage in the requisite activities they may need to do to manage their physical health, whether it's take their medications regularly or engage in healthy behaviors, then you've been able to, through a behavioral health intervention, reduce the downstream costs to the healthcare system because that patient is no longer showing up in the ED as a frequent flyer. So that's one example of the connection between the two. And I want to invite Karen and Ethan to provide some other examples.
So
This is Ethan. Oh, sorry, go ahead.
Oh, go ahead, Ethan. That's fine. I can go after you.
I was going to say, this is Ethan with Sound. One of the things that we're really working on with our client base and with our clinical staff is making sure that we can support the overall system with following up with individuals that have presented in the ER. So we get a fairly live feed through the collective medical portal when one of our clients hits the ER for any reason, and then we use that as an opportunity to reach out to them, see if we can help them with coordinating care, follow-up, connecting with the services that are recommended, as well as kind of making sure that any medications or anything that were prescribed and documented in the ER, we're making our medical staff and prescriber aware of so that they can account for that and the treatment for clients. And then the other thing that we're doing is we're educating our staff around the 5 chronic conditions that Washington State is really targeting and just giving them basic education and comfort in dealing with and talking about those things and taking that a step further then, and also making sure if we have groups or individual treatment or individual sessions with clients where there is work or information going on around their health goals, that we are connecting them to the basic things that they need to do that. We've been really good about addressing social determinants of health, and now we're looking at this of just a step further. So one of the examples I like to give to our staff when talking about this idea of how do we help support the health of our clients. One of our locations, we have a baking group, and they do a lot of cupcakes and cakes, which is great. It gets the clients there and they're invested. Unfortunately, a lot of those individuals also have some diabetic or metabolic issues, and so we want to make sure that we're helping support them. And so we're changing kind of how we do that group and really addressing, what are healthy substitutes we can do that still, give clients what they want to eat, but maybe are helping reduce some of the risk factors by substituting oils or sugars for other things that have less impact. And then we've built a registry around identifying those individuals that are at metabolic risk so that our medical staff and our clients can help be aware of who's at increased risk in doing that. And then we have a registry around who are our high utilizers and our super utilizers that are showing up in the ERs more frequently, and making sure that we are intervening to either get them connected or help address the social determinants of health that are driving that ER usage, either in the community or through primary care services.
Yeah, and I want to address the questioner's question about payment. So in that example, Ethan, your organization could potentially negotiate or advocate to receive a care management fee from a managed care organization for all of that coordinating activity you're doing. Or your organization could potentially participate in an accountable care organization, and through all the activities you're doing to reduce cost, you could help the ACO be successful and have some kind of shared savings agreement. So that's how we would translate those activities that you're doing on the ground to improve quality and reduce costs into one of these value-based payment models with payers.
Exactly,
Karen?
and that's what we're doing as far as trying to lay that groundwork. Our current pay structure doesn't allow for that, but again, it goes back to being able to tell the story and tell how we positively impact the lives we serve.
Yeah. Karen, do you want to comment briefly?
Sure. We're doing many of the similar things. Who are our high utilizers? How are we wrapping in their families or their other supports to help stabilize them and keep them out of the ER so that they're not in there. One of the things that we're doing with Kaiser Permanente at Youth Care's Orion Center drop-in is a physical healthcare, behavioral healthcare integrated clinic where they have physicians there a couple of days a week, and we have a psychiatrist there for about 4 hours plus therapists, so that homeless youth and young adults who are struggling on a number of levels can get health care, and it's also a way to sort of engage them in behavioral health with the idea of let's address their health care costs or their health care, physical and behavioral health care costs where they're at, instead of them advancing to the point where they have to get to an ER and utilize that service. So trying to be right where the folks are and create an environment that can address both behavioral and physical health care issues and substance use. There's some medically assisted treatment out of the Kaiser Clinic as well.
Great, thank you.
And we have SUD therapists there, so yeah, like that.
So it's all about demonstrating to the payer the value that the behavioral health organization is playing in impacting the quality of care and the cost of care, and then figuring out the compensation model, whether it's a reward for hitting quality metrics, whether it's participation in an accountable care organization. There are different payment models that could be in place for a behavioral health organization. Alexis, was there another question?
Yeah, there were a couple of questions that I'm going to try and wrap up into one or two. The first of which was that there's an understanding of how this value-based payment model is shifting for healthcare organizations and behavioral health organizations, and there seems to be an understanding of the role that social determinants play in that value. But we have a couple of questions related to how social service or community-based organizations get involved or get compensated for the value that they're contributing to this model if the payment streams are still coming through MCOs, which traditionally have contracted directly with health organizations and not CBOs.
Yeah, so that's a great question, and it's one that is a very hot topic, not just in Washington State, but around the country. So there is definitely a growing recognition and awareness that social determinants of health really impact that cost curve. And if you want to bend that cost curve, you need to go outside of the traditional hospital and clinic walls. And today, there aren't payment mechanisms that allow managed care organizations to compensate community-based organizations for the services they provide. But some states, starting with North Carolina, are actually testing out and piloting a model where it's called the Healthy Opportunities Pilot in North Carolina. And they're essentially creating a mechanism whereby, just to oversimplify it, community-based organizations could essentially submit claims to their services to managed care organizations to be compensated for the work they're doing to, keep people out of the acute healthcare system. And this is still very much in pilot mode. But other states are doing things to encourage connections between providers and community-based organizations. What you're seeing, Manat is actually conducting a very detailed review of state Medicaid managed care contracts for information about social determinants of health. And what we're seeing is that a lot of states require their MCOs to screen members for their SDOH needs. Do they have a housing gap? Do they have food issues? Are they suffering from interpersonal violence? And then the state is requiring MCOs to connect those members who have unmet social needs with services. And then they'll take it a step further, and some states, not the majority yet, but some states require that the provider who makes that referral tracks that the service is actually delivered. So in that way, you're progressively seeing more and more expectations placed on providers to refer and make sure those services are delivered. And as those expectations on providers increase to coordinate with CBOs, then the incentive to connect with CBOs and to reward CBOs and to invest in CBOs and their capacity to meet these needs increases. So I think we're very early on in this concept of using healthcare dollars, traditionally, through managed care organizations, to reward CBOs for the work they do in meeting these social needs that people acknowledge play a huge factor in people's health and the healthcare cost curve. So it's starting, but it's in pilot mode. But we're seeing things like the need to screen. And Twee, this might be a good opportunity for you to talk about the discussions that are happening around community information exchange and how Healthier Here hopes to foster greater linkages between clinical providers, behavioral health providers, and community-based organizations.
Thank you, Naomi. I was thinking the same thing. Yes, so we've, Healthier Here has started this exploration with the use or utility of a community information exchange in King County. And we began that discussions probably, I would say, about 3 months or so. And I would not be surprised if some of the attendees on this call have attended our last session where we had the discussion introduction or teeing up the CIE discussion. What I can say is that we at Healthier Here are very serious about exploring this and actually innovate and do something within King County for the duration of, or at least leveraging the waiver, the waiver dollars investments to do that. I can also say that we are Healthier Here is in the stage of our strategic planning of discussing what our investment strategies for the upcoming years, 2020 and 2021, with our board and committee members. And the CIE is an area that we will be continuing our efforts in that. So what I would say is that we will be having several more collaborative discussions between our CBOs and clinical folks, partners, and that to stay tuned. And more information is going to come as we unfold this journey, as Naomi puts it. We are very interested in pursuing this so that it would create that. We see it as a valuable tool to create the linkage between community and clinical partners as we move forward with this, the VPP, and also to address social determinant of health in our county, in King County.
Great. Thank you, Twee. We are at time. We're happy to send around the slides. There were a couple we didn't get to, but I think we hit on really the highlights. And I want to thank again our two guest organizations, Ryther and Sound, Karen, Krystal, and Ethan. Thank you so much for joining us and for providing insights into the activities your organizations are doing to transition your care model so that you're ready for value-based payment. We will circulate the slides and we'll circulate an evaluation. And if this was helpful, Twee, I believe there's opportunity for further training in the future. Is that right?
That's correct, Naomi. We will be looking at the survey results, any input or feedback, and there will be, stay tuned, there will be more conversations coming.
Yeah, great. So just to let everyone know, when the webinar ends, the evaluation will pop up on your screen if you have a few seconds to fill it out now, but it will also be coming out in a follow-up email. So if you're not able to fill it out right this second, we will be able to fill it out online. And I know there were a number of questions that came in that we actually didn't get to answer, so we'll circulate kind of a Q&A transcript, both for the questions that did get addressed, but also those that didn't, just so everyone can see that information as well.
Great. Thank you, Alexis.
Thank you, Alexis.
Okay. Well, thank you, everyone, and have a wonderful afternoon.
Great. Thank you.
Thank you.